Welcome to Method to the Madness.
Nailed it. Let's go.
My name's Steven,
My name's Elijah.
and we want to tell you a little bit about ourselves, kind of why we're here, what we're doing. So Elijah, can you kick it off?
I can.
Yeah. Who are
All right.
you?
Well, my name's Elijah. As we said, I'm a medic student over at Wake Tech, almost complete with the program. Fellow student of Steven Yakubowski, the man, the myth, the legend. We all know him. We all love him.
Stop it. I'm blushing.
Yep.
Yep. So my name's Steven, Steven Yakubowski, also a Wake Tech student going through the paramedic program. And if I'm correct, we're about 93 to 94% done.
That's correct.
Yeah.
We did the calculations.
Yes, we did. And we got them, and they were noise.
Yep.
So we are excited. We are fired up. And so kind of today what we want to do is we want to talk to you about patient assessments, why it's so important. As paramedics, how are we going to go ahead and be assessing these patients as like new EMTs, how are you going to go ahead and make those assessments as well, right? Because patient assessments, they're not just for paramedics,
Yep.
right? But
Oh,
they're
yeah.
for EMTs as well.
Yeah, and it's something we should be constantly improving on.
Yeah.
We can't just go through it and
Right.
never stop learning.
Right.
We got to keep building on it.
Yeah.
Without a full assessment, especially if you're going into paramedic,
Yeah.
when we have these ALS treatments, we need to make sure we're leveling up our assessment. We need to know our indications, our contraindications, when to do something, when not to do something. And then, Steven, if you want to look at it, I know you had a great analogy of kind of looking at it like a painting as
Yeah.
well.
Absolutely. But no, like even to go off what you said, Elijah, like I completely agree. And it is so important for us to be able to do good assessments, right? Good patient assessments. So the analogy I want to give to you, right, is I think we should be going and looking at these assessments kind of like a painting.
Right.
Yeah.
Right.
I don't know about you, but I don't like half-done paintings.
Nope.
I don't like paintings that are started and not finished.
I agree.
Right, but I think going through this assessment process, right, we are continuing going like step by step by step, right, like building the base, building that foundation, continuing to add a little bit more detail, so we can kind of see what's going on with that patient and figure it out.
Yep.
Right, because we want to be the best providers that we can be for these
Absolutely.
patients.
Absolutely.
It is exactly what they deserve. I know if my mom or my dad was to get sick, I would want these paramedics, these EMTs, to be able to give the best assessments.
Absolutely.
So they can figure out what's going on. Right, and I think as you go through like those little details, that next step, right, it starts to become a little bit more clear what's going on. So it's like, man, I hope my paramedic ability is a lot like Van Gogh with his painting ability.
Absolutely.
So it is nice and
Yeah.
it is good.
Yeah. And the way we're going to do this today, guys, is we're going to go through it. You've all heard it before, the scene size up, the primary, the secondary assessment, the reassessment. But we're hoping that when you leave and you're done watching this podcast, that you're going to have some tips, some tricks, and some better advice to do this at a higher level.
Yeah, absolutely. So I think as we're going through this today, I'm going to be putting Elijah through a trauma scenario.
Whoa now.
Okay, so Elijah, let's get into it.
Let's do
All
it.
right. So the first thing we're going to be talking about today is our scene size up and our general impression. All right. What can you tell me about that? And as you're going to this trauma scenario, what are you thinking through?
So a lot of the thinking happens before we even enter the scene at all, especially if we're going to be paramedics.
Yeah.
We have to think of ourselves as leaders of the scene. We have to know
Yeah.
how to effectively manage a scene.
Yeah.
So before we even roll up, we need to start thinking.
Yeah.
We need to start thinking especially about what kind of resources we're going to need.
Yeah.
When we go through that, we say, I'm going to consider additional resources, but do we really take the time to consider? Because some calls, they just go better with more sets of hands.
Yeah.
So that's something that I put a lot of emphasis on, is thinking ahead.
Yeah.
Thinking what we might need, what we might be getting into. And then once we arrive on the scene,
Yeah.
is looking.
Yeah.
Taking a couple seconds to look around and see
Right.
what we have. So for
Yeah.
example, on a trauma scene like an MVC, we want to look at cars that we have.
Yep.
We want to look at the damage to the cars.
Yeah.
And this is going to help us think ahead, think ahead of what we might be expecting.
Yeah.
And if we know what we're expecting, we know what treatments we might need in our back pocket for later on in the call.
Yeah.
So that's just a great way to get started. And then kind of going along with that, when we see like damaged vehicles or we see just places where high mechanism of injury can occur, we just have to start thinking, especially about stuff like trauma criteria.
Right.
That's why it's so important to just constantly go over this type of stuff.
Yeah.
Because we can figure out a lot about a patient before we even make contact with them. You know?
Absolutely. By the stuff that we're seeing all around, right? Like you take a look at that vehicle and you see that front end is completely pushed in. Like,
Absolutely.
right? What I'm going to expect some stuff. You know, I'm going to be like, man, what just happened to this patient? Did he just bust out his lungs? Did he bust out his chest from that steering wheel? You know, I'm looking for cracks on the windshield as well of like, when did he hit his head? Did he go through the windshield? You know, like how fast was this patient going?
Right.
And I think even one thing too, as I'm thinking on my way to the scene, right, is I want to make sure I know it sounds silly and it sounds dumb, but I got to make sure I have my right PPE.
Absolutely.
You know?
Absolutely.
And not only just the PPE, making sure I got the gloves, you know, am I going to need like my suit to go into the car? Like, is the firefighters going to have to go break some glass?
Yeah.
You know, but I also want to make sure that the scene is safe, you know, because if this scene is not safe, I don't think I should go in it.
Yeah. Because when we're called out, we know it's an emergency.
Yeah.
We know this patient is in trouble, but we cannot just go running in.
Yeah.
We're paramedics now, so we have to think very smartly. We have to use a method.
Yeah.
And that's why, you know, method to the madness. We're going through our steps
Let's go.
in a very calm and collected manner so that we don't miss anything.
Right. Yeah. And it's hard to help somebody when you need help.
Oh, yeah.
You know what I mean?
Yeah.
And I think that was one thing that one of my paramedic friends told me a long time ago is like, you know, Steven, you got to make sure you are safe first because, you know, if you're not safe, you can't help those people, right? And it's like, I don't know, but like being a new paramedic or potentially a new paramedic of that, like I want to help as many people as I can, you know, so like if there's like a mass shooting, do like the superhero complex, run in there, put the tourniquet on, save people.
Right.
But it's just like, but in reality, it's like, hey, I can't be treating people if I'm hurt, you know? And so that's also another thing as well. So what are some of the other things that you're looking for as you're starting to get to the scene?
I'm also looking for what my other people on scene can tell me.
Yeah.
You know, a lot of times when you're in a more urban environment, you've got fire, you've got police on scene.
Yeah.
I know it's not like that all the time in a rural setting.
Right.
But they can tell us a lot already because a lot of times fire will go get you information.
Yeah.
They've seen stuff before you've even arrived on scene.
Absolutely.
So getting a rundown, getting a briefing.
Yeah.
From whoever's on the crew first
Right.
can give you a big mental picture
Yeah.
of what you're going into.
Yeah.
And that's, I mean, that's what you need.
Yeah.
Because we don't
Absolutely.
just walk in, you know, willy nilly.
Right.
We like to have a plan.
Yeah.
Plans are good.
Yeah. Kind of like a method to the madness, you know?
Wow.
There it goes again, guys.
There it goes.
Yeah. All right. So here's the deal. We thought about our scene safety. We thought about our BSI. We talked a little bit about mechanism of injury and nature of illness, right? And so now you're at the scene. We got resources coming. You are at this vehicle. Here, I'll even give you the scenario here, guy.
Sure.
So this scenario is you just arrived to a dispatch to a motor vehicle collision with injury on a 2-lane rural road, reported of a 2-vehicle T-bone crash with airbags deployed.
Okay.
All right. So what are some of the things you're thinking?
Some things I'm thinking of are we're in the ambulance. We got to make sure before
Yep.
we even step out, we've got, appropriate traffic vests. We've
Yeah.
got gloves and all that. And then we got to think about how we're going to plan the scene.
Yeah.
We got to think about where we're going to put our ambulance.
Yep.
We want to put it in the most optimal position to protect the scene.
Yep.
Because protecting the scene not only protects the patients, it also protects us.
Yeah.
I want to make sure I've got fire en route.
Dude, I wasn't even thinking about that. That's good.
Yeah.
That's good.
Yeah. I want to make sure I got fire en route.
Yeah.
I'm going to need more hands.
Right.
2 cars, that means I know I have at least 2 patients
Yeah.
right there. That's why it's so important to just start thinking, I need additional resource.
Yeah.
you can always cancel them.
Yeah.
You know, and then just like kind of going back to knowing like your trauma criteria and stuff. Sometimes you don't even have to see very much to know that you're meeting some of that trauma criteria.
Yeah.
If you're going up and you see somebody's partially, kind of outside the vehicle, partially ejected from a vehicle, stuff like that, you know you're in trauma criteria.
Yeah.
You know that patient's got to go to a trauma center.
Right.
Yeah.
Yeah, and I also think too of like, right, when we're going into our general impression, you know, we're walking up there, we're at the scene, we know how many patients, we know how many resources we got to call, we're always considering C-spine. But I think when once you take a look at that patient, you could really start to see kind of like, not necessarily what's going on with the patient, but kind of how bad off is that patient.
Oh, yeah.
Right. So it's like first glance, you know, like how old is this patient? What position is this patient in? You know, kind of like what is his distress level? Is he breathing? Is he not? You know, is his airway open? Like what does the skin look like? What does it feel like?
Absolutely.
You know, so being able to make sure we're taking a look at all those things, you know, really getting that first impression, or like that general impression is really going to help.
And so something I want to ask you is, from your experience, what are some things that, you know, whether it be a trauma or medical call that you look for in a patient that would tell you this patient's in distress and we need to think about moving a little quicker with this patient?
Yeah, right. Absolutely. As I'm looking at them, you know, I'm kind of looking for some signs of shock, right? Like, is this person sweaty? Is this person like calm, cool, and collected? Does this person have an altered mental status?
Right.
You know, and if this patient has an altered mental status, why does he have that altered mental status? Kind of like what you were saying before of talking to the people around, you know, maybe some of the people that know him or know her. And so it's like, you know, being able to go and to talk through that stuff with them. You know, like, is this person kind of like at his normal baseline, or is this person somewhere else in a whole another universe or something, you know? And so I think it's just, those are just some of the things that I'm looking for and like some of the things that I've seen. So it's like, if I'm seeing that this patient is starting to be in shock, you know, maybe as like you look at them, like they're just not there. And so it's like, yeah, we should probably get moving pretty quick.
Yeah.
You know, I think also too, like when I first get there, and if it's medical or if it's trauma, you know, one of the first things I'm looking for is like, is this person bleeding out?
Right.
You know, it's like something I've learned pretty quick, that it's like, if you will bleed out faster than you will lose air. You know what I mean? And then correct me if I'm wrong about that, but it's like, I'm making sure that I'm not seeing any pools of blood, doing a rapid exam real quick, going all the way from the head, all the way to the toes, you know, and just taking a look at this person, making sure that he's not bleeding out, making sure there's not any arterial bleeds that are like shooting, right? Because, you know, if that's the case, that's the first thing we got to take care of. Another thing I'm looking at as well is I'm looking at the patient's airway. Like, my second thing is making sure that airway is open. You know, I want to go ahead and check with that patient. Like, I'll say, hey, sir, ma'am, how you doing?
Absolutely.
You know, see if they respond, if they talk to me. And if they talk, you know, I know kind of that their airway is pretty clear, and it's like, how many words are they saying? Are they saying one, two, or are they speaking a whole sentence? You know, and so it's like, I'm making sure that it's open, I'm making sure that it's clear, and I'm making sure that it's manageable, right? So it's like, if this patient is coming up and his airway is filled with vomit or filled with blood, filled with whatever, it's like, I know I got to go ahead and I got to suction, right? And so making sure I'm doing that. If I find the person on the floor on a trauma, you know, do that jaw thrust maneuver, or maybe do like that head tilt, chin lift, if it's more of a medical call like that.
Yeah. And I like what you're saying about all that.
Yeah.
For sure. And just something I would add, kind of from what I've seen, is a lot of these patients are not going to be just supine. You know, laying down with the palms up in the anatomical position. You know, we run into patients a lot that are on their face. You know, they're prone. Or just in a position that's not great where they're breathing. Right. Just a little movement of the head affects how you're breathing.
Right.
And when we see patients in a position like prone or something, we have to think about moving them.
Exactly.
Yeah.
Yeah, absolutely. Right. Or it's just like, too, of like, hey, maybe if you just sat that patient up, that patient will be able to breathe better.
Absolutely.
You know, maybe that patient has CHF or something else that's going on, or like he has the rails in his lungs, and so like let's sit this patient up so he can breathe more. Right, and so we talked about our X, we talked about our A, so now let's go ahead and talk about our B. Right, so the airway's open, the airway's patent. I'm also going to check out his breathing. You know, what is that rate? What is that rhythm? What is that quality? You know, like what type of effort? Do I see a bunch of accessory muscles on his neck, on his chest? You know, or you know, am I just seeing him being able to breathe normal? You know, I'm looking for chest to rise and fall. I'm listening to lung sounds as well. I'm looking for some cyanosis, like on the fingers or the toes. You know, I'm looking for all those different type of things. And honestly, like if the patient does look real off at first, you know, like more of like an emergency situation, I'm going to go ahead and probably check his end tidal as well.
Oh yeah.
Right, because I want to make sure he's getting a good pleth of good breathing, you know, making sure it's in like that 35 to 45 range.
Okay.
Yeah.
And tell me about how you prioritize like lung sounds, because I feel like lung sounds are something that we should be getting early on our respiratory patients. It's not something that we can kind of delay. So what are some patients that you would think about getting lung sounds right off the bat?
One, if I know if it's a respiratory call.
Oh, yeah.
If they say, oh, he's got shortness of breath, all right, let's see why. But yeah, basically, like if there's any respiratory issues and if I'm seeing them using those secondary muscles, because it's like, right, we cannot physically see his lungs, you know, but when we take our stethoscopes and we go ahead and we listen to those lungs, again, it's painting that picture, right, giving us a little bit more detail of what's going on in those lungs, right, and so like we're listening for rails, we're listening for bronchospasms, right, we're listening like to see is there any wheezing, you know, and then after that, we're going to go ahead and treat accordingly.
I agree with that.
So again, it's like those are some of the things that I see when I look or when I hear about like those respiratory calls that are coming and different calls that are coming our way. So yeah. Well, so if you could, if you'd be so kind. We talked about the X, talked about the A, talked about the B. What's next? Elijah, what are you looking for?
The next thing is going to be circulation. And this is so important. One of the best pieces of advice I've ever received is that we should be making contact with our patients in some kind of way quickly. And one of those things can just be feeling a radial pulse. You know, because not only can we feel that pulse to feel whether it's rapid, slow, weak or strong, but we can also feel the skin. Because we know cold skin's a bad thing.
Not ideal.
And because we want it to be pink and warm, and just based off a little touch like that to the patient, we find out all those things. And that's a big idea for this is like, we don't need to do so many advanced things to figure out what's wrong with a patient.
Right. And that's why it's important, like when we're talking with our EMTs as well, of just, you know, these assessments tell so much, right? And even like when you're going back to the circulation, right, if we're feeling for that radial pulse, if we don't feel one, we could tell that this patient, he's not in a good way, right? Like his blood pressure, his systolic blood pressure is going to be potentially less than 80, right? And so like, again, like there's another sign of, hey, let's go, let's move, let's get this patient out of here.
And then kind of moving on to a little bit of like the disability and neurological section. That might be something for some patients that we have to delay until we're in the ambulance and on the road. But this is such a crucial part. And I dislike seeing people skip over this. So such as we have a fall, let's go ahead and check pupils. I mean, we cannot just make the determination sometimes that, you know, this patient's going to be fine. This patient's going to be fine. Because a lot of the times we have some time on the ambulance. And we should be doing our more in-depth assessments. And that includes stuff like pupils. That includes stuff like checking motor function on both sides of the body. You know, stuff like that.
So Elijah, I got a quick question for you, right? You're talking about the pupils. What are some of the things that the pupils can show if they're off?
I mean, just something that is easy to see, even if you don't have a lot of experience, is if the pupils are different sizes. You know? That can indicate some kind of brain bleeding, indicate pressure building in the head. And so as paramedics, we need to think forward, more forward and forward and forward into the call, thinking that could get worse.
Yeah.
And we have to think about our ALS treatments.
Right.
The question is, what can I do for this patient right now that can help them?
And that's right. And it's so true to what you said, like, right, talking about those brain bleeds, there's not much we can do, right? Correct me if I'm wrong, but there's not a lot that we can do. And we know that we got to get this person to the hospital.
Yeah.
Right. Yeah. So we talked about the brain bleeds, right? Like, we see pupils that are pinpoint, it's like, man, he might have taken something he probably shouldn't have. Maybe that's why he's unconscious right here on the ground.
And something I would love to add to that is I'm very glad you brought that up, because
That's what I'm here for.
patient that's unconscious, their eyes are closed.
Yeah.
So we're not just looking at them. We're not staring at them in the eyes. If we skip over parts of our assessment, we can miss something that is so crucial.
Right.
And we don't need to think about this as like, I'm only going to check pupils on, my older patients, my adults. We need to check them on the kids too.
Yeah.
Because in the world of EMS, crazy things happen to people we wouldn't expect. Considering stuff like overdose in a baby or an infant that's has a decreased respiratory rate is something that's crucial, and we cannot miss it.
And you're so right. And it's like, for example, I saw one at my hospital clinical.
Absolutely,
right? My pediatric hospital clinical. There was a baby that came in, and he was given, I believe it was 0.4 milligrams of, not nitro, what's it called? Narcan, by the paramedic on the way, and he was able to get his respiratory up a little bit. But like, the baby went into cardiac arrest because he overdosed on drugs, that he got a hold of somehow, some way.
And that's just an example of a paramedic doing a full assessment
Yeah.
and finding the solution out of that full assessment.
Yeah.
The eyes are a small part of the body, but they told exactly what was happening in that situation.
Yes. Right. And making sure that when we go to these patients, making sure that they're alert, that they're verbal.
Oh yeah.
All that good stuff.
Yep. Kind of the next section would be exposing our patients.
Right.
And this kind of falls into more of that trauma category.
Yeah.
But if somebody's complaining of pain in a part of their body, we should think about looking and putting eyes on that part of the body.
Absolutely. Right.
But on the other hand, for a trauma patient, we want to check every part of their body. And like I said earlier, we want to drop tips for you guys to just kind of learn from what we've seen. And one of the biggest things is, like we said earlier, patients are not always on supine.
Right.
If your patient's on their side or they're prone, let's quickly scan that back.
Yeah.
Because once we immobilize them, I mean, just trying to do a log roll later into the call is going to give us a lot more problems than if we do that off the bat and check before moving.
Well, and that's the thing. it is so easy to forget the back.
Oh,
Whenever we do TSOP scenarios, for some reason, I always forget the back. And it's just like, man, that back. And kind of like what you said, when we are doing these full assessments, we are continuing to get the details in there, trying to paint that picture to see what's going on. So rapid interventions, right? So when you are thinking about the XABCs, what are some the interventions that you're thinking about doing, and why would you do them?
One of the first ones I think about, and that many people, even in the civilian world that have little medical experience, know, is a tourniquet. Or any kind of bleeding control device. Those are immediate things we can do. And then another one is oxygen. I know it's one of the most used medications out there.
Absolutely.
Because we look at fixing the basic stuff first. Oxygen fixes a lot of things. And we have to also be cognizant of the fact that when we have a trauma patient or we have a critical patient, we don't want them to become hypotensive, and we don't want them to become hypoxic. Because as good providers, we want to do full assessments, and we want to make sure that we look for a good outcome for patients. We want to fix things, but we want to fix them at the right time so that they don't damage the patient further into the call.
Absolutely. Right. And guys, I know that we've said this probably 2 or 3 times now, but guys, it is so important to make sure that we're doing full assessments, right? That we are getting that clear picture and that we're not missing anything. So, right, we did our primary assessment. Maybe we're going, and now we're going to go ahead and do our secondary assessment. Right. Some of these things that, again, is another part of the picture.
Yeah.
Right. Now we're past the foundation. We're past that base color. You know, maybe we're starting to draw some like little trees in the background and stuff.
At this point in the call, we should be on the way to the hospital.
Yeah.
And just based on the type of call, we got to prioritize what treatments we're going to do on scene.
Yep.
And what treatments we're going to do in the secondary aspect. And so that's kind of where we're headed right now, into the secondary aspect. I'm gonna let you kick it off with a good sample. I know you love the sample, and everybody else should love it too.
Love the sample, dude.
Everybody else should love it as well.
Dude, absolutely. And I think we should love it because, again, it's another thing that just tells us so much of what's going on, right? So the sample, going through that real quick, you know, the signs and symptoms of like, hey, you were like, when did these symptoms start? You know, if a patient is like having a stroke or something like that, you know, it's important for us to know, when did that altered mental status happen? You know, when did that altered mental status start? You know, and also with us being able to go ahead, give medications, you know, like what type of allergies does this patient have? You know, is this patient allergic to morphine? Is he allergic to aspirin? Is he allergic to Tylenol? You know, all those different things. It's important to know that. Again, it's like maybe this person is allergic to bees, and you go to a park and you find a stinger in the patient. Oh, he's probably having an allergic reaction. You know, so let's go ahead and take a look at that. Again, it just paints the picture. You know, what are some of the medications that this patient is on? You know, like, does this patient have hypertension? Does he take medications for that? Does he take medications for his blood pressure? You know, right? And so it kind of goes and continues to paint that picture. And then with that medication, his past medical history. You know, what are some of the things that he had in the past? You know, because I remember there was a scenario one time of I think it was like an 8-year-old that was having trouble breathing. You know, and one of the questions we asked was like, well, has he had this happen before? And they said yes. And we asked him again, what happened? They said, oh, he had to get intubated. And we're like, okay, now we kind of know like what's going on a little bit, and like maybe how people treat it in the past. Again, we're looking for those signs, we're looking for those symptoms before we do that treatment. But it's good to let you know. You know, it's good to help you, right? And then last, oral intake. Right, what were the last things that you were eating? And I know it sounds funny too, but what was the last outtake as well? Right, like, how have your poops been? Great question to ask. You know, like, how have your pees been? Like, are you dehydrated? You know, like, is there blood in the stool? Like, again, it's just adding more to that picture. And then what were the events leading up to this as well? You know, so it's like, what were you doing before this happened? You know, like, people, again, with heart conditions, you know, like, oh, my chest was hurting as I was mowing the lawn, you know, but then after I stopped and I sat down, you know, it's showing us another thing of like, oh, maybe this guy has angina, you know, and maybe it's stable, maybe it's not. But again, it's kind of giving us more of a picture of what's going on. Some other things we should look at too is our OPQRST. Right. And what this is talking through, or helping us be able to go through the different pain scale of what is happening with this patient. You know, like, what was the onset, the provocation, you know, what is the quality of your pain? What would you rate it on a scale from 1 to 10, the severity of it? And then also time, right? Is it time for OPQRST, or is it tenderness?
Time.
Good. You know, that's DCAP BTLS. So many acronyms. But with that as well, you know, when did the pain start? How long has it lasted? And then where is it? And then has it stopped? Has it gotten more severe? Has it not? You know, being able to look through those things as well. Yeah.
And we kind of went over that head to toe assessment. And just something I wanted to add to that is, if you're doing that in your secondary, if you want to check out one part of their body, go ahead and check out the rest of it. You know, we don't really just break stuff up like that. If you're going to do something, do it the entire way. And then one great thing I'd add to the medications thing is a simple question I love to ask it to every patient is, I know you're on these medications. Have you been taking them? You know,
Absolutely.
Some people,
Yeah.
that could tell you if you've been off your seizure medication for a week and
Yep.
this person has been having a seizure. Well,
Yeah.
I'm not Einstein, but you know, yeah. And
Yeah.
something else that is vital is vital signs. They tell us and they kind of confirm what we've seen. If we see a patient
Right.
in distress, then we look at their vital signs and something's out of whack. That's something we know we need to fix.
Yeah.
And just taking the time, like once we get a full set of vitals, taking 10 to 15 seconds to look at them in context
Yeah.
and just try to put that picture together.
Yeah.
One thing I absolutely just love is knowing trauma criteria. I'll go back to that
Yeah.
because there's trauma criteria that has to do with vital signs as well.
Yeah.
We got to know this kind of stuff. We should be able
Yep.
to see it, know it, and like apply that, knowing where we need to transport, what we need to do for that patient.
Yep. Not just trauma, but sepsis too, right?
Absolutely.
Yeah.
I have to agree with that for sure.
And so, like when you were talking about vital signs, what are some of the vital signs that you do with each one of your patients?
The basic ones,
Yeah.
we all know them: the heart rate, blood
Okay.
pressure, SpO2.
Yep.
But these are big things.
Yeah.
Something as simple as oxygen can help a patient.
Yeah.
When we talked about earlier, and we could come up on a scene in somebody's altered mental status, it could be stuff as simple as hypoxic.
Yeah.
And we need to fix that.
Yeah.
And we need to make sure we get our other vital signs too. They don't have to be immediate. Sometimes we have to put other vital signs like end tidal,
Yeah.
blood glucose,
Yeah.
and temperature off.
Right.
But guess what? We got to get these on patients. For
And
sure.
and I think a big thing is when you go to that scene of knowing kind of what vitals are important, right? So if you're dealing with somebody with an altered mental status, you know that the blood glucose level is going to be an important one to get right away.
absolutely.
You know,
Absolutely.
but if you have somebody there that maybe is having like some heart issues, right? Maybe the BGL isn't as important.
Yeah.
But again, it's like these are our secondary assessments, and like you definitely need to get a BGL at some point in time. But again, these are just those secondary assessments as we're looking through them.
Agree with that.
Yeah.
Next, guys, we're going to move on to kind of special considerations that we have for patients.
Yeah.
And the first thing we start with is just the difference between trauma and medical assessments. I know we kind of catered this towards kind of a trauma approach, but let's just think simply and just think about time difference. Know when to move quick and know when you have a little bit of time on scene. Also know your different types of screenings like stroke screens, all this other kind of stuff.
Yeah.
Because we apply them in different situations and we got to know them. We got to know them by heart so we can get them down quick.
Yeah.
And also looking at stuff like 12 leads. Trauma patients, they can get a 12 lead, but it's not something we're going to prioritize over when we have a call that has a medical nature unknown. We need to prioritize stuff like that.
Right.
Because we can't see all the clues from outside, but when we get to that point, let's start looking for clues inside.
Right.
So let's look at the 12 lead. Let's look at VGL like we mentioned.
And
stuff
those
like
lung
that.
sounds as well, like
Yeah.
we were talking about earlier.
Oh yeah. Uh-huh.
Yeah.
Agreed.
Right. And also some special considerations you need to think about is what patient are you treating, right? Like, are you treating a geriatric patient? Are you treating a pediatric patient, or are you going to be treating a pregnant lady, right? All of these people have different considerations to be thinking through, right? So like for a pediatric patient, right, they got those big heads. I know my son, he does have a big head, right? And so
He's a smart guy.
he's a smart guy, right? And so, but with that, it's important to make sure that we put the padding underneath the shoulders so that they can have their airway open, right? And their airway, so that patient go ahead and breathe. For our geriatric patients, right? Some of them, with them being older, right, they might have lower blood pressures. Not only that, but their skin is a little bit softer. So when we're dealing with those patients, we're moving with those patients, maybe some of those patients have scoliosis. So as we're putting them onto the stretcher, those are there padding that they need as well for like their head, because like their back is so deformed. And then like for OB patients as well, like, if they're in their third trimester and they're laying straight on their back, we got to make sure when they're laying on their back, sometimes it will cause the patient not to be able to breathe as well. And so when you go ahead and turn them on their left side, the baby isn't pushing on all that stuff in there, right? And so, right, and also like when we as paramedics talk about like knowing our medications, knowing all these, is like there's certain medications that we could use for each one of these patients, right? And we got to make sure that we're thinking ahead, right? Like I know like for pediatrics, we got to make sure we know our pediatric dosages.
Oh yeah.
For geriatrics, we got to know how will that patient kind of react to that medication. And the same thing like for a pregnant mama, you know, of like what medications can we give this mom as well so it will not affect the baby.
I like that.
Yeah. And so another super important thing is, right, we were there, we treated the patient, we saw the patient, we helped this patient out. And so one of the final things, we end up to the hospital, and now what? Right now we got to go ahead and communicate all of our findings during the handoff, or maybe even when we're on the ambulance as well, you know, of being able to make sure that we're able to do a good call-in, making sure that we are clear, making sure that we are concise, right? Not drawing a whole bunch of things out, but kind of like systematically thinking through that call. What are the important things that we need to tell the doctor of what's going on, what happened, maybe being able to communicate some of that history that was going on with that patient. But those handoffs, right, is getting closer to the end of that call. Is kind of like putting like those extra details in that painting, like, right, we talked about the trees, putting like the little leaves and the little apples, and stuff like that. But Elijah, what are your thoughts on the communicating your findings and all that?
I think it's something that we have to master. As paramedics, we got to master it. Just as we see the picture, they did not see the picture. They were not on scene. Hospital staff was not on scene. We have to paint a picture for them. And so we want to do that, but we don't want to include information that's not pertinent. Hospitals want to know a set of information, and as you go on, you'll learn that. For example, seizure, they want to know, did you get a blood sugar? Or stroke, did you get a blood sugar? And stuff like, we say we want to do full assessments because hospitals will ask you about this kind of stuff, because they want to know if it's already been done and what are the findings when it's been done. That is so critical, is learning how to speak with the hospitals.
And like bringing us back, or bringing us to like that next part of, right, we talked about the communicating the findings during the handoff or during the radio report. And so now, but like as we're in the ambulance, we're driving home, or not home, but we're driving to the hospital, right, we got to do like our reassessments, right? And so like you gave that medication, what did that medication do for that patient? You know, did it help them? Did it make things worse?
Absolutely.
Right? Because if you give the wrong medication, you know, you don't know what's going to happen. So I guess like a question I got for you, Elijah, of like the frequency of the reassessments, like how do you think we should do that?
Frequency of the reassessments, we say, 5 minutes for trauma, 10 minutes for medical. In my opinion, we should be reassessing these patients constantly. We should position ourselves in the ambulance beside the patient. And for some patients, I agree, it's okay to sit in the captain's chair. But just remember, you cannot see that patient's face. You cannot see their eyes. We want to make sure that this patient stays conscious. We want to make sure we can see the monitor. And we are just looking for changes. We're asking, did this help? And more importantly is, if it's not a critical call, is how can I help you? How can I make you more comfortable? I think one of the biggest things is there's also resources we can provide for patients. And so get to know your patient during the reassessment, and see what you can do to help them, you know.
And I have another paramedic friend who once told me, as like I was starting this journey, and even like as my EMT, as I was starting that, they said some of the best medication that you can give a patient is communicating with them and talking with them.
Absolutely.
Right, because you are trying to get their mind off what was going on, that pain level and all that different stuff, you know. And I think just as providers, being a good provider, being able to communicate with that patient is huge, and it's key. Because when you're able to communicate with them, you become a better advocate, because you're starting to see some more things that's going on with this patient, you know, and going back to being an advocate for your patient, you know, going back to when you're communicating with the hospitals, or when you are communicating on what is that thing called, on the radio,
Mm-hmm.
because when you're communicating, you know, and you're trying to be an advocate for this patient, you want them to get the best care that they can have.
Agreed.
You know, and so again, it's like making sure that we're doing that whole assessment again, you know, and looking through that as well.
And just one little thing I want to add is
Yeah.
looking for trends, looking
Yeah.
for deterioration in our
Yeah.
patients, and looking for stuff if it's getting better.
Yeah.
Because when we see a problem, we have to fix it, and a lot of these issues that we hear about nowadays are, paramedic in lawsuit because they did not notice this happened or they
Yeah.
did not address this.
Yeah.
We have to constantly be looking at that kind of stuff. And
Absolutely.
especially as paramedics, we have so much more available to us.
Yep.
As an EMT, if somebody's blood pressure drops to nothing over nothing,
Yeah.
there's not a whole lot you can do.
Yeah.
But as a paramedic, we know what we can do for that. Fluids,
Yeah.
drugs, stuff like that.
And even too, like as an EMT, right? Being able to communicate with the paramedic of what's going on, right? And so like you're looking at these, like, right, like how many times has it happened where maybe like a paramedic said, yeah, this isn't really that bad of a call, let's just go ahead, give it to the EMT, and the EMT is looking for this, right, looking for those signs. He starts seeing the signs of deterioration, and he goes and he needs to communicate that to the paramedic, right, so the paramedic can do his job and be able to help out as well. Because honestly, I've like through class, you know, like we've heard horror stories about other paramedics, you know, that gave the call to the EMT, and the person ended up going into cardiac arrest, and the EMT never saw it, didn't see the signs or symptoms, right? And what happened, you know, the paramedic, I'm pretty sure the paramedic lied about it, and you know, and it's just like, as paramedics, EMTs, emergency medical services, you know, we need to take this job seriously.
Absolutely.
And each patient, like, I know sometimes like you're on your 6th, 7th, 8th call, but it's just like, it is so, each patient is going to be different. So it's important that we give them the time and the resources that they need for the help that they can get.
Yeah.
Yeah.
Yeah. And just kind of for that section, wrapping up, is that when we do something for a patient, we should always just be looking for what happened after.
Yeah.
What happened after we did it.
Right.
And that's an easy way to think about it, is just what next?
Yeah.
You know, what next? What now? Those are just good questions to ask yourself.
Right.
Um,
Man. And so Elijah, I think we covered a lot today.
we did.
Right? We talked about the scene size up. We talked about our primary assessments, our secondary assessments, you know, and we went again and talked about our reassessments as well.
Yeah.
I think one more thing that I wanted to add to all this, you know, is great medics. We don't just follow a checklist, you know, but we are taking a look and seeing the story, seeing the picture of behind the signs of what's going on, you know. And so again, I think it's important for us to reinforce critical thinking, you know, over memorization of that checklist as well.
I agree. It's just one of those things. Like, that's one of the biggest pieces of advice I can give, especially during paramedic school, is try to understand the why behind something. Don't just do things, because just following a protocol, just following steps can get you in trouble. Understand what you're doing. And that's the whole point of medicine, is to understand and
signs
apply
and symptoms.
and apply
Right.
that, you know?
Yeah.
We can do a lot of crazy things, but if we're not doing them at the right times for the right patients, to fix the correct things, we've done a disservice.
Yeah.
And that's not doing medicine efficiently.
Right. I'd agree. So, any closing remarks? Any closing encouragements? Some professional insight?
Some professional insight.
Yes.
I've got some amateur insight. I wouldn't say it's very
We're not
professional.
getting paid for it yet, you know?
Yeah. But yeah, just understand how to manage a scene. That is the biggest thing as a paramedic, is delegating tasks.
Yep.
You have a team. People are looking to you to be the leader.
Yep.
You know, show no fear, right?
Yeah.
We have to be the most medically knowledgeable people on scene, and we have to be able to take care of people efficiently, and just
Effectively.
and just be a good leader, right?
Absolutely.
Anything from you that just from your experience, that was my biggest thing.
Yeah.
What's your or one of the biggest thing or things that you've learned?
No, one thing I would just add on to that, Elijah, is I don't know if I necessarily learned it as like an EMT or a paramedic, but more of just like going through life. Is everybody has their skills and everyone has their abilities, and some people are better at things than others.
Right.
And I think as paramedics, we kind of need to know what our strengths are, what our weaknesses are. When we look at the different staff members or the different employees for that county, kind of what are their strengths and their weaknesses. And as paramedics, we got to be humble. And so if we know that another person could treat that patient better than we could, I think it's important that we don't live on a high horse and are able to go ahead and let that other person go ahead and care for them, but always just, again, I think it goes back to being a patient advocate. And again, I hope that this podcast was able to paint a picture for y'all, that you can see why each detail is so important.
Absolutely. Every detail.
Yep, from the beginning to the end, and making sure that we could go ahead and just be the best paramedics that we could be. And so on some closing notes, Raven, I just wanted to say thank you so much for all the time that you have put into us, making us the best paramedics that we can be. I don't even really know what else to say besides thank you. You crushed it, and I am so thankful to be able to call you my teacher, and I'm so excited to see all the other EMTs, AMTs, and paramedics that you're going to teach, just because they're going to go out and do great things because you're such a great teacher. So I just wanted to say thank you.
Absolutely. And I want to say thank you too. There were a lot of topics during paramedic school that seemed very challenging at first, and
Yes.
that I was like, how in the world am I going to learn this in a couple weeks?
Yeah.
But Raven, I got to admit, you explained things and you taught us things in such understandable ways that I couldn't have asked for a better teacher to become a paramedic. I feel confident, and a lot of this stuff that we talked about, I feel like I learned during the class and from you.
Right.
Thank you very much.
And so we hope you enjoyed the episode of Method to the Madness.
Oh yeah.
And we hope you guys have a great day. Again, this is Steven.
This is Elijah.
And we hope you have a great rest of your day.
Make sure to like, subscribe, donate,
Please be kind.
Everything. Donate everything you've got.
Oh, yeah.
Thanks, guys.